Yeah, so as you said, I really have never left my Latin America or Hispanic community. I was born in Cuba, and then went to Panama, and the Panamanian people received me and my family with open arms. I always say I'm Cuban by nacimiento, by born. I was born in Cuba, but my heart is in Panama because my daughter and my wife are from Panama. And then I study in internal medicine and infectious disease in Miami, which actually it was like an extension of Latin America in the US. And then I finally came to the US, New Mexico, and it turned out to be a minority state. And I feel really at home celebrating the Hispanic heritage. I really miss very little of Latin America being here and having so many friends and being able to keep my culture alive. So let me talk a little bit about the impact of COVID-19 pandemic, and it's actually a very sobering lecture. Although we're celebrating our Hispanic heritage, we also have to face the realities that our people, nuestra gente here in the U.S., doesn't always have an easy time. So I'm going to talk about, first of all, identify how impactful the COVID-19 pandemic has been among the Latinx or Hispanic community here, especially in the US, explore the reasons or possible explanation for this phenomenon, because I think we need to learn from what has happened and try to make changes for the future, because for sure we'll have future health crises and future pandemics. And I'm going to propose or sort of share some ideas, the way that I think things should improve for minoritized populations in the U.S. to make it easier. And I have practiced medicine both here in the U.S., in Latin America, and also in Spain. So I have sort of a limited but a somewhat global perspective on how healthcare should be. To begin with, I'm going to share with you actually a review. It's a little bit old. It's for 2002 about the infectious disease that disproportionately affect our community or the Latinx community. And we can think about these infectious diseases as diseases that are acquired in their country of origin. And as you know, problems like tuberculosis and neurocysticercosis are very prevalent in Latin America. So when people move into the United States, unfortunately, they carry some of these infections in dormant ways and can reactivate. So there's a higher likelihood of developing this disease, and some of the ones that are listed in this comprehensive review. But there are also problems that develop while they're living in the United States, associated with, as we should see, with many social determinants of health, and I'm going to talk about that later. And one of the salient examples is HIV. HIV, it's also prevalent in our population. 25% of people who live with HIV in the U.S. are or Hispanic or Latin ethnicity, and that's an overrepresentation of the people of this specific group. And things like H. pylori, which are also associated with lower socioeconomic and economic disadvantage, are also more prevalent in Hispanics. So there are multiple infectious diseases and obviously non-infectious, non-communicable diseases that are more prevalent in our group, and it's important to recognize that and to try to see what are the root causes of those problems, and try to always fight for better health for our people. And to be honest, when the pandemic started, I should have thought of this, but I never thought that there was going to be such a disproportionately impact on the Hispanics, on Native American, and also on African American. I thought, this is a respiratory virus. It transmits through the air. It's going to affect everybody the same. But really, it has been a completely, for me, a relative surprise. Maybe I shouldn't have been surprised, but for me, as an infectious disease, I said, well, this is going to affect everybody similarly. But just looking at the CDC data, and this is a relatively up-to-date data, you can see that minorities, especially American Indian or Native American uh, non-Hispanic, Black, and Hispanics have been disproportionately affected. As you see in this slide, probably two times higher number of cases, almost 3 times higher hospitalization, and over 2 times higher numbers of death among Hispanics. So it's definitely been very impactful in every way. I'm going to be sharing with you more detailed data. If we look at the COVID cases in general, in the Hispanic or Latino population, you can see in red is the percentage of cases, and in gray, the gray bar is the percentage of what they represent in the US population. So there's always obviously a much higher prevalence or incidence of COVID-19 in our group, in Hispanic, Latino, and also American Indian and Native have been also heavily affected. And we knew that very early in the pandemic when we saw the problems with the Navajo Nation and the number of patients that we saw here in UNM transferred from Navajo Nation. At some point in the pandemic, especially with the first wave, if you belong to one of these, either Black, Hispanic, or other races, you had almost twice the chances of having a positive COVID test if you went into a COVID testing area than non-Hispanic white. So there was really double the risk early on in the pandemic. If we look at the hospitalization, because it was not only the frequency of infection, but also severe disease. And you can see here, this is data relatively updated from the CDC on COVID-19 confirmed hospitalization in different ethnic and racial groups. And you can see it's very easy to see that these 3 groups that are almost 2 to 3 times higher the number of hospitalization than non-Hispanic, white, and Asian. So there's really disproportionately number of hospitalization among minority groups, and obviously Hispanic or Latinx are one of the most affected groups regarding hospitalizations. So it was not only infection, but also severity of disease. And it's not only one age group. You can see these are the hospitalization rates per 100,000 population by age. And you can see that all age group, even kids, younger adults, and all the groups, the ratio, it's several times higher for Hispanic compared to whites, which was the reference rate here. So 3 times in kids 0 to 17, in young adult 3.8 times more hospitalization, 50 to 64 3 times, 65 another 2 times, etc. So definitely this is not something that affected only one group, maybe the working group, but it actually affected all age groups equally in severity relative to the people belonging to the non-Hispanic white racial group. And even if you look at the first, and this is an impressive, probably the most impressive percentage that I've seen, this is a report from CDC from the initial 135 deaths in kids with COVID. And out of those 135, which mostly die of COVID, some die of the multisystem inflammatory syndrome, which is a complication. 44.6, almost half of the death at the beginning of the pandemic were among Hispanic kids. So this was really, really, really impressive and really surprising for, from an infectious disease standpoint and from all points of view, the disproportionate number of kids who were, despite being a relatively non-severe disease, that among the death with COVID, it was over the kids, Hispanic kids were overrepresented by far, and these have long-term implication because of the mortality that occurred during the COVID pandemic. The life expectancy has been also reduced in minority population. For instance, in African American, the life expectancy have decreased by 2.1 years, which takes years to actually recover, and for the Latinx population, 3.1 years, and this has increased the gap, the so-called black-white life expectancy gap from a difference of 3.6 to 5 years. So it's really impressive the impact of the pandemic on certain ethnic and minority groups. And even I was even more surprised by this here in the U.S. If this is a study by Paulson published in the Journal of Immigrant and Minority Health. Even if you look at just the Hispanic and you ask them, how if they define themselves as white Hispanic, black Hispanic, or mixed race Hispanics, you can find a difference in mortality and hospitalization just by the color of their skin. Hispanic blacks experiencing the highest hospitalization rate in this graph and the highest death proportion of deaths in this graph. So even within the Hispanic group, and that's something that we know really well, that Hispanics or Latinx are not a homogeneous group. It's a very diverse group. But even looking at this, just at something as simple as the color of the skin can predict the risk of hospitalization and mortality. And there's got to be many explanations for this. But that was also surprising for me to find when I was researching for this topic. So the question, obviously, I think I have made a clear picture of how hard the pandemic has been on minority group. Why are we disproportionately affected? What are the reasons? And I think the answer lies on the social determinants of health. And I'm going to make an argument mentioning what I think are aspects within the social determinants of health that predispose minorities to a more severe respiratory infectious disease like SARS-CoV-2 or COVID-19. And just as a review, the social determinants of health in a sort of a simple way are classified: the healthcare access and quality of care, the neighborhood and the environment where you live, the social and community context, the economic stability, and aspects related to education, access, and quality. And as you will see, I think all of these aspects of social determinants of health put minorities in a disadvantage and predispose them to worse outcome and to higher incidence of infection. Things like lack of access to quality healthcare have been documented, lower access to health insurance, and also the lack of adequate linguistically and culturally responsive healthcare system. They all combine really to make life harder on minorities here in the U.S. And things as simple as access to testing, access to treatment are also limited for minorities. There is a lot of published evidence on how minorities live in neighborhoods which are less than perfect, and there's the lack of affordable and quality housing, which is conducive to crowded conditions within the house, more people, more housing units per building. Also, minorities live closer to factories, to highways, and this is associated with exposure to air pollution. And we know from the pulmonary literature and from environmental literature that pollution also it's a risk factor for worse outcomes with respiratory diseases. And also use of public transportation and crowding in metros and other settings also increase the risk of exposure to respiratory diseases. Obviously, inequities in access to high care education or high quality education are important, because some of the messages, some of the discussion that occur in social media or even regular media may not be understood by our people because of the higher health illiteracy and higher limitation with language understanding. And finally, the economic instability. We know minorities and Latinx in the United States are overrepresented in essential work settings, so they were not able to stay at home or work in factories and food production processing plant that are associated with lower health and working conditions for them and making them more susceptible to infection. So there's really, as you can see, many reasons that I think are associated with some of these now obviously not surprising findings that minorities were affected during this pandemic. And just to give you an example of some of the publications, there was early in the pandemic a study from Newark, New Jersey, in which they found a very high mortality, in-hospital mortality rate, and the great majority of the patients who were hospitalized and died in New Jersey early in the pandemic were patients from the highest quartile for population density, the living in high number of housing units, and had also lower income. So those are socioeconomic factors that affected directly this population early in the pandemic. Even in Utah, they did a study using an index of deprivation, and they found that those with in high deprivation areas, or what they call very high deprivation areas, had 2 or 3 times greater risk of COVID infection. And obviously, those high deprivation areas had an overrepresentation of Hispanics and non-white residents, people who worked in manual work, essential work, public-facing sectors, obviously exposing them to infection, even when there was already orders to stay at home. And in fact, everybody remember, I think this made to the national news, the outbreaks among the poultry and meat processing facilities. And in those facilities, there were close to 16,000 workers who developed COVID in those processing factories. And of those, 87% belonged to one of the racial and ethnic minorities. So that was another important risk factor for exposure. And we can see that Hispanics are overrepresented in grocery, convenience, and pharmacy, which didn't close during the pandemic, and also childcare, and also cleaning, building cleaning services. Many of these were not really shut down during the pandemic, and before, obviously, vaccination was available. So, and also, it's a well-known fact, and there was a study using the medical expenditure panel survey in which they measure what was the percentage of household who had at least one person that couldn't stay at home, and they found that Hispanics or Latino adults, 64% living household with at least one worker who was unable to work from home, compared to 46% of non-Hispanic wives. So there was a greater exposure, not only of that worker, but also the worker coming home and infecting their household or part of their household. So there are many obvious factors for increased risk of infection. I have sort of mentioned some of them, but there was another surprising, aspect, and is the more severity of the disease, more hospitalization, and more death among minorities, especially among Hispanics. And in fact, if you look at this is a pre-publication of excess death among Blacks and Latin compared to whites. In Connecticut, which is not even a minority state, and you can see there was a 74% increase in excess mortality and 63% in Latinx. So even in a state where minorities are really a small percentage, their excess of death was much higher than whites. So what are the reasons, or what do I think are the reasons, and what have been at least hypothesized in the literature are reasons for increased severity? We know what are the risk factors in general for more severe COVID-19, and we know that age, advanced age, male gender, and some comorbidities are associated with severe COVID-19. And we know that there are two of the most significant comorbidities, obesity and diabetes, are more prevalent among Latinx compared to other racial and ethnic groups in the United States. And in fact, these are the complete list of medical conditions that are associated with severe COVID according to CDC. These are actually the indication, for instance, for monoclonal antibodies. And you can see diabetes and obesity are there. And to some degree, also liver disease. Liver disease is more prevalent in Hispanics than in other groups. And also, there's indirect effect. Obviously, people with obesity and diabetes will have more chronic disease and also stroke and heart conditions. So, although as a whole, the population doesn't have a higher prevalence of those diseases, when you look at the predisposing factor like obesity are more prevalent in Hispanic communities. But there are also social determinants of health and other aspects that can make the disease more severe. One is, it's obvious, is delay in care, and there's a lot of publication. I just citing two here, but there are publications showing that for instance, minority have more frequent testing in hospital than an ambulatory setting for COVID-19 during the pandemic, meaning that they were really tested when they were sick enough to go to the hospital and not electively in outpatient settings. And this was almost 20% for Hispanics were tested in hospital as opposed to 5% in non-Hispanic whites. So that tells you that there's delay in care and lack of access of care, which may be associated with more severe disease. And in fact, there was a very early study from the radiology literature, not even from ethnic or racial studies, but actually the radiologists who were reading the X-rays found that, and this is a publication, as I said, from July, so relatively early in the pandemic, July 2020, in radiology, in which the authors, the main conclusion of this radiographic study was that racial and ethnic minority patients were more likely to have increased disease severity from COVID-19 in the admission chest radiograph. So they were presenting later with more advanced disease for the reason that I have explained. And there are obviously other reasons, as you know well, language barrier, which according to the Office of Minority Health, 72% of Hispanics speak language other than English at home, and almost 30% state that they're not fluent in English. And we know that the language is a problem associated in the literature with increased emergency department visits, longer inpatient hospitalization, and worse clinical outcomes. So that can also translate into having a worse outcome with COVID-19. And obviously the elephant in the room, the issue with immigration, the farm workers, the illegal farm workers, the legal temporary workers in the U.S. Have many issues with their immigration status. Obviously, fear of deportation, the mistrust in the medical and public health, the exclusion from insurance coverage eligibility, limitation of personal finances because of their immigration status. All of these really combine to make their, when they're facing a disease or an infection, make their less likely to seek care, to go to the hospital, to be tested, because of these fears or misconceptions. And then, so there are many reasons, and I just summarize here, which I think is my take on why Hispanics and other minorities have had more severe course. Obviously, the biological reason, or one biological reason, may be just the higher frequency of certain comorbidities, but also, as I mentioned, delay in care, the language barrier, the immigration problems, and also misinformation. This is something that have been explored in the literature. A lot of the Hispanics are frequent visitors of Facebook, Twitter, and other social media from their countries, and in many Latin American countries, there have been a plethora of misinformation regarding COVID. So this leads to confusion. And I can tell you, some of the patients that I saw here at UNM, when I asked them about, the vaccination, or if they had think about getting vaccination, obviously COVID patients, a lot of them said that the vaccine was not effective, or they were afraid of this or that other fallacy that they read or heard their family members, because they had access to less than trustworthy information. And finally, there may be some genome or genetic predisposition. There are some data on interferon signaling pathway, inheritance, and also differences in HLA haplotype. But this is something that it's really in its infancy. People are studying if certain ethnic or racial groups or have more or higher prevalence of these negative or disadvantageous mutation. But we have to really wait for more data into that regard. And not only are minorities affected more frequently and more severely, but also the economic consequences of the mitigation strategies that were implemented affected minorities to a higher degree than other groups. Obviously, loss of wages, unemployment have been a consequence of the pandemic, loss of health insurance. Many families Hispanics in poverty have food insecurity and housing instability during the pandemic, and not all of them were able to get government help because of the other issues that I have mentioned. So it's not only worse disease, more frequent disease, but also the economic impact of the pandemic and the measures that were taken during the pandemic that affected the rate. One good news, if there is some good news on this thing, is that vaccination, it's not that dissimilar among the different racial and ethnic groups. And you can see 53%, this was, I think, up to September 20, the Kaiser Family Foundation actually gathered data on vaccination percentage by ethnic and racial groups, and really the Asians have been in the forefront with the highest percentage of vaccination. Hispanics are here 49%, and blacks are a little bit lower than Hispanic in this analysis, 45%. But it's not that significantly different from white. So at least in that aspect, there's not such a huge difference between the ethnic and racial groups. And actually, if you look at the last 14 days from this analysis of Kaiser Permanente, the Hispanic was one of the fastest growing group getting vaccination. So at least the message is getting out, and people are getting vaccinated among the Hispanic of Latinx group. What needs to be done? I just have a couple of more slides on my final thoughts. The CDC put out actually a strategy in response to this reality, to these disproportionately cases in Hispanics and other ethnic and racial groups. And they actually came up with sort of 4 strategies. Trying to collect more information was the first strategy, which I think it's important, expanding the evidence base, but also expanding programs and practices for testing, contact tracing, isolation on those heavily affected, and also creating programs to support frontline workers, especially workers in processing plants and other. So at least there was some effort directed towards decreasing this issue of these inequalities and these problems that I have. But I think the most important thing is to work on the social determinants of health, and there's a lot of room for improvement here in the U.S. In my opinion, healthcare should be a universal for everybody here, regardless of immigration status, regardless of socioeconomic status. We have to develop more linguistically and culturally responsive healthcare for minorities in the U.S. Definitely, there should be sort of an overarching plan on improving housing and development and policies for clean air, especially in the inner cities where minorities reside. Obviously, we as a healthcare have to partner with community workers and have more community engagement and try to come out of our silos, our hospitals, and actually try to do more primary care, more community care, more hospital at home care than just trying to heal people who are very sick. Actually go and do a primary prevention. And finally, obviously, continue to work for more education of our people, higher education, both in general and also improving health literacy with language and culturally appropriate material. And obviously, improving working conditions, especially for essential workers in future pandemics, with paid sick leave so they can go and get vaccinated or get tested. And definitely, as I said, the other issue with the Latinx community, the big problem with the lack of a comprehensive, coherent immigration policy. So in summary, I think we need to, if I can, summarize everything in three bubbles. The first is to try to eliminate structural and systemic racism and inequities that affect, as I put here in Spanish, nuestra gente, our people. Also attack all of these problems with the social determinants of health. And probably in the more local, immediate things that we can do is implement local and regional practice to improve access of care to minorities, testing, treatment, especially vaccines in this case, in the case of COVID, and also what I mentioned, community engagement. Thank you. I think that's all that I needed to share. And this is a beautiful sunset in the Bexar Canyon Arroyo, a photo that I took with my cell phone. I live very close to the Bexar Canyon Arroyo, and this is a beautiful sunset that I have really grown to enjoy here in the southwest of the United States. I'm going to stop sharing. Thank you very much.
Thank you so much, Dr. Sosa. What a wonderful presentation. Before we started, I meant to say that I lost my dad to COVID. So I keep following the data. I too was a person worried about getting a vaccination because I have multiple sclerosis. But I think that the more information, the more education that we continue to learn will help us, not just with ourselves, with our families and our community, to ensure that we are getting the proper resources to protect ourselves. So with that, I'm going to turn it over to Dr. Parada, who is actually supposed to be the moderator, pero se me olvidó because andamos locos, locas ahorita. So Dr. Parada, my apologies, and I'll let you go ahead and ask questions as well as if anybody else has questions.
Thank you, Dr. Gomez Chavez. And you've done a great job with all of the planning for this. So thank you so much for all of your hard work. And thank you, Dr. Sosa, for your time and your expertise. I've had the pleasure of working with Dr. Sosa during the pandemic and working on several different projects. And this talk is informative and staggering and not surprising, unfortunately. So thank you for bringing this data to us today. And I also wanted to mention that Dr. Sosa was recently awarded mastership with the American College of Physicians, which is a huge, huge honor. So congratulations, you deserve that, Dr. Sosa. We appreciate you. And I just wanted to see, is there, what questions do we have for Dr. Sosa right now?
Well, I want to ask, I have two children in college. They both received the vaccination, but as we hear, right, that younger children might be able to receive it. What are the implications to that? And is there enough study? Should we, what is your opinion with that?
Yeah, I think we are going to see very soon the data in younger children, meaning less than 11 years old. There's going to be a meeting with the FDA to present the data and actually publicly discuss the data from the study that have been done in 6 to 11 years old, because the Pfizer, one of the companies that are making the vaccine, is actually requesting emergency use authorization for that age group. And I think at the beginning of the pandemic, there was this perception that kids were not affected, but we have, as you saw in some of my slides, we have accumulated data that children are affected. Maybe not like an 80-year-old or a 70-year-old, but there are kids affected both by severe COVID, and we saw it with the Delta wave, an increase in the number of pediatric cases in several states, especially in the South. Kids are also vulnerable to the long COVID. So if they recover or they have a mild disease, they can develop these long pervasive symptoms with COVID or post-COVID, in which they may not be able to do sports again, or for some time they may have difficulties concentrating. So there's significant sequelae that have been well described in children. And they also have this rare, it's really rare, but it's very severe multi-inflammatory syndrome that puts him in ICU with low blood pressure, heart dysfunction. So it is not negligible, the impact of COVID. So I think once we see the data, if the vaccines are safe in that age group, I think it's going to be recommended because the risk outweighs the risk of the disease outweighs the risk of the vaccine. And I think it will be an individual decision, but I think the data will show that it is protective. And they're going to use adjustment of doses, so the doses are going to be smaller in kids. So that's going to decrease the adverse events and any concern that we may have with the vaccination.
Thank you. I know we all struggle with this with our families, and of course, we want to keep them safe. And the more information that comes out, it's kind of like we knew we're suspected, and now, you know, we're kind of getting some confirmation. So hopefully we'll help our vaccine hesitant people move forward and getting the vaccination. Other questions for Dr. Sosa?
I do have one more question. And if our medication is not on the list to approval for the booster, I've heard mixed messages that yes, you should go ahead and get it, or no. What are the thoughts about that?
Yeah, that's a good question. And it's actually subject of a very active debate right now among experts. A few premises. Number one, we know that all of the vaccines give you a very good protection against severe disease and hospitalization. Even 6 to 8 months out, the protection is very, very decent. But on the other hand, we have seen waning of protection against mild infection or asymptomatic infection. So people who are more conservative and they don't want to see any cases or any infection or any transmission are obviously advocating for booster shots. But really, the impact of a booster shot or a third dose in general population is probably not going to make a big difference regarding mortality, because mortality has been controlled with the vaccinations, or hospitalizations and severe disease have been well controlled with 2 doses. But in a few countries, Israel mainly and UK, we have seen some waning of protection. So that, I think that's the main reason, and especially here in the US with the surplus of vaccination that we have, I think the government have made this decision to increase the protection by giving a third dose to a large proportion of people. I mean, people over 65, those between 18 and 64 with comorbidities, which if you look at the indication, is there's a lot of comorbidities listed, and even a BMI of greater than 25. So almost everybody has a BMI over 25, or a large percentage of the US population have over 25 BMI. So when you look at the indication for vaccination, it's very, very broad. And then you include teachers and healthcare workers and frontline workers and police and firefighters, etc. So the numbers are very, very high that are, at least at this point, the boosters are recommended by both CDC and FDA.
Dr. Parajon, did you have something?
Yes, hi. My name is David Parajon, and I lived in Nicaragua for many years. My heart is, part of it is still there, but most of it is here in this beautiful place of New Mexico, where I met my wife, actually. Dr. Sosa, I had a question for you. It's just regarding the data. Is there similar data available or becoming available on New Mexico, just New Mexico? And if these disparities are observed here too? And also, because of your connections, I imagine you have still the connections in Panama. And I wanted you to maybe comment on Panama and what's been observed there too, internationally.
Yeah, no, I don't, actually I should, but I don't know to the same degree of granularity the data in New Mexico. If we have looked at a disparity, obviously I can tell you anecdotally, after the first wave, when we saw mostly patients coming from the Navajo Nation, a significant percentage of our patients here have been from Hispanic or Latinx ethnic group. I mean, and Dr. Parada can tell you, we saw a lot of patients when we were looking for patients for the clinical trials, the NIH-sponsored clinical trials. A lot of our patients from the Hispanic community here in Albuquerque. There was, a significant proportion, but I don't know, the exact percentages and how disproportionately affected they have been with numbers specifically from New Mexico. I know the data that I've seen published for the nation as a whole. I can tell you a lot about Latin America. Latin America has been not only Panama, but Latin America have been one of the areas of the world most affected by COVID-19. Brazil, Colombia, Peru. Peru, for instance, have the highest lethality. There was a very high percentage of people dying of COVID. And I can tell you, because I have colleagues in Peru, at some point, patients were not even going to the hospital. They were dying at home. I was in the data safety monitoring board of one of the vaccines, and there were a few patients who died in the trial, and they basically died at home. There was no necropsy or autopsy. There was no hospital. I mean, the sponsor asked for, why don't you send us a copy of the hospital record? And the people there, the researchers said, no, this patient basically didn't go to the hospital because there was no bed, there was no access to care, zero. I mean, so they die gasping for air, sitting in a sofa in their home. It was really horrible. In Guayaquil, I can tell you, there were dead bodies on the streets at some point because they couldn't bury their death, and they basically put it out on the street for like the public health authorities to pick them up. So it had been really horrible. Brazil, Manaus, the Amazon area has been horrible, and Panama has also been heavily hit by the pandemic. So Latin America, I didn't mention that in my talk because it was mostly concentrated in Hispanic here in the US, but it's been really, really hard on them. And governments have not been, close to science, to put it in a mild way. They have been also populism, and they have used unproven therapies like hydroxychloroquine and ivermectin. We actually make jokes of that in Panama. We call it the happy meal, the happy box, because when you're diagnosed with COVID, the government, the Ministry of Health, gave you a little box with acetaminophen, ivermectin, hydroxychloroquine, and a whole bunch of other things, sort of a consolation that they were doing something for their people, but it was obviously nothing helpful. Maybe except for the Tylenol, but for the acetaminophen, but the rest was basically more harmful than useful. So it's been very hard in Latin America. On the other hand, vaccination has been embraced. There's very little anti-vax. In my country, we are in the high 70% of people vaccinated. Chile is number 2 or 3, or was number 2 or 3 in the world in vaccination. So there's this other good part that the people have embraced vaccination despite the limitation and despite the fact that they didn't have access to all of the vaccines, but they were able to get some of the Chinese vaccine, the Russian vaccine, and some of Pfizer and AstraZeneca, and are vaccinating their people with whatever they have available. So that's a good thing, or a silver lining of this horrible situation.
Thank you.
We have time for maybe one more question, if anyone has any.
I'm just shocked by the numbers that Dr. Sosa showed. It's incredible, how disproportionately affected the Latinos, and actually the Blacks too, and Native Americans are also really, it's incredible how they've been wiped out, nuestra gente. A lot of people affected, yeah.
We have a lot of work to do, and that's why we're here. And thank you so very much, Dr. Sosa. I know we have some studies going on for the social determinant data, including race, that Dr. Crystal Chan has been working on with some of the data from the COVID follow-up clinic. So more to come on that. And again, thank you everyone for your time. Dr. Gomez-Chavez.
Muchas gracias, everyone. Thank you again for your wonderful commitment, the work that you do each and every day on behalf of our community, on behalf of, your own communities that you represent here in the US. And what you do for New Mexicans every day. We appreciate you and we honor you during National Hispanic Heritage Month. So muchas gracias, buenas noches, and please join us mañana at noon as we honor los primeros, las primeras. Hasta luego.
Bye.
Bye.